Good morning, everyone. Welcome to Friday Chalk Talk. My name is Patrice Fidel. I'm your facilitator today. I have the pleasure of introducing our two guest speakers to talk about diagnosis and prevention of aspiration pneumonia and ethical issues surrounding um, aspiration pneumonia in dementia. To start, we have Dr. Amanda Rosen as a third-year pulmonary critical care fellow at New York Presbyterian Weill Cornell Medical Center. She went to medical school at Northwestern University, completed her internal medicine residency at Columbia University. She will be staying at Cornell as faculty starting in July. Outside of medicine, she'd like to take her cockapoo named Obi for long walks and do strength training classes on her Peloton. And then Dr. Brad Hayward is an assistant professor of clinical medicine at Weill Cornell Medical College in New York City. He did a fellowship in hospice and palliative medicine at Columbia University Medical Center and a pulmonary and critical care fellowship at New York University. He currently practices both pulmonary and palliative medicine, and in his free time likes to run and nap with his dog Arnie. So welcome both of you, and I will mute myself, and the floor is yours. Thank you for being here.
Thanks for having us. So I'm really excited to talk about this topic with you guys. And thank you to Brad, who's been just an excellent mentor throughout all of this. Um, this talk is going to kind of pull from a paper that Brad and I wrote together, kind of a review of this topic. A shameless plug, there's a lot more references and kind of more detail into like what we talked about here. If anyone, any one of these particular topics interests you, feel free to kind of delve further. So we're going to be talking about a couple issues here. The first is the diagnosis of aspiration pneumonia, some nutritional decisions that are subsequently made for these patients, and then we'll kind of wrap up with a case that I thought was important to talk about patient-centered decision making. Okay, so this is not a shock to anyone that pneumonia is a common disease and it is also a common cause of death. You can actually find one of Osler's original medical writings that has been scanned up into Google Books. And I found one of his quotes from there that describes pneumonia as, quote, the friend of the aged, which implies it is a way out for people who are at the end of life. So it's been going on for a long time. We obviously know a lot more than we did in 1892. And we know that community acquired pneumonia is often caused by aspiration, micro or macro events. Um, and if that is the case, then what exactly is aspiration pneumonia? Like, how is that exactly different than community acquired pneumonia? And I would like to argue that the short answer is we don't know. We don't actually know what aspiration pneumonia is. There is not a unified definition for this disease. That is probably the case in more diseases in medicine than we'd care to admit, but this is especially the case for aspiration pneumonia. So this was a review paper that looked at 9 different studies that were studying aspiration pneumonia, and they wanted to see who was diagnosed with this condition. And this is just 4 of them. And you can see that all of these studies had completely different requirements for what constituted aspiration pneumonia. Some clinicians said you had to witness the aspiration. Some said you just had to have risk factors. Some used radiography. So it's kind of a heterogeneous condition. And that matters, right? And I'm sure you've all experienced in one setting or another where a patient comes into the hospital and they've been kind of labeled as having aspiration pneumonia with a wide array of evidence. And I think that matters. I'm not sure if any of you have children or if you remember this book from childhood. It's all about cause and effect. Um, if you've never heard of this book, basically the idea is that there's a mouse and he asks a boy for a cookie and the boy gives him the cookie and then he would like some milk and then he would like a napkin for his whiskers and it goes on and until this whole day for this boy has been taken up all because he gave this mouse the cookie. And I think that aspiration pneumonia sets off this kind of chain of events that I thought that book was sort of a cute way to embody. It causes this cascade of things that is going to kind of change how we take care of our patients, specifically how we feed our patients. And that matters. It matters for all of the reasons that food matters for patients, but it also matters because it kind of feeds back directly into the ability of a patient to recover from their initial insult. So this is kind of a unique situation where the diagnosis then kind of begets potentially future instances of the illness itself. This was just sort of a, a diagram that Brad and I drew up to describe this kind of paradigm. There's several iterations of this. And this is what I think we're going to talk about. So one thing that is commonly done when patients have a diagnosis in the chart or clinical suspicion for aspiration pneumonia is we place an NPO order. This is done with the complete good intention of making sure that patients don't have recurrent aspiration, ongoing aspiration. We don't want to worsen their condition. And I think what I learned in kind of looking into this is that this is not a benign order to place, as I think for years we thought it was. When you're not feeding people, they don't recover from illness. And we know that's the case in many illnesses. And it's the case in pneumonia too. This is just one paper that I found that actually, it was observational, of course. They didn't randomize people to this, but they looked at, excuse me, patients who had an NPO order and then early time to feeding again, either a nutritional evaluation or kind of within 48 hours they were given food, and then patients who had kind of a prolonged order for NPO. And the patients who had the prolonged NPO order took almost double the time to recover. I think it went from 8 to 13 days. This is also something that I'm sure many of you have seen, these texture modified diets. I don't know if any of you have actually tried them. They're fascinating. I wouldn't call them tasty. So they were developed for this problem, right? The idea being that we are trying to minimize the amount of contents going from the mouth into the lungs for patients who are at risk of having aspiration and developing pneumonia. They don't really work as well as I think we had hoped. They had actually been developed in the 80s and 90s, and they were originally studied with radiography, meaning the original trials that were developed in order to suggest their use was watching patients swallow with barium swallow studies, and they could see that there was less radiographic aspiration. And it hasn't really borne out to demonstrate a consistent reduction in this entity of clinical aspiration pneumonia. Again, there's not randomized trials for this, but this was sort of the best quality one that I found, where they looked at patients who had thickened liquids versus a regular diet order. And while they didn't have a lower rate of intubation, they did not have a lower rate of overall respiratory events, which included choking and a diagnosis of pneumonia. So potentially some benefit in one metric, but not overall and not clinically. And again, as I alluded to, people really don't like these diets. The adherence to them is really poor. It's hard to teach people when they go home how to use these diets. It's hard to give them to them in the hospital, and let alone when a care partner is kind of sent on their way with telling them every bit of liquid has to be thickened. And I think this is very important. Not, this audience especially will understand, but for any physician and care team, these patients are potentially at the end of their life, and to kind of condemn them to a life of having all thickened liquids when maybe they don't work as well, I think is a really important consideration. So I've now posed problems with two of the things that we usually do to prevent this illness. And it makes logical sense that if we can't swallow, we should just bypass that system, right? We should put in a tube either in the nose or in the mouth to prevent aspiration pneumonia. That logic makes a lot of sense, and families kind of really, it logically fits, and so families often cling to it. And unfortunately, we also know that we don't really prevent aspiration pneumonia with these placement of these tubes. When I started doing this research, there's been a lot of there is evidence to suggest that it increases the risk of aspiration pneumonia. That evidence is not super strong. But I feel very confident in saying that we know they do not decrease the risk of aspiration pneumonia. This is just one paper to show that it didn't really improve that outcome at all. And we know that any kind of tube placement or any kind of procedure in patients comes with risk. So this kind of goes back to the idea with these thick and liquid diets, right? If we're worried about some of the risks, as we've outlined here, and there is less benefit than we originally thought, I really do think that should kind of change our calculus. One thing that as I was researching this topic that came up was patients who have dementia and have any kind of exogenous thing in their body, including a tube, they are want to pull it out because it's confusing. It promotes delirium, and they have been shown to be more likely to be restrained, either chemically or mechanically, which I thought was a really important thing to discuss with families. Okay, so there is a whole range of options for patients who have been labeled with aspiration pneumonia. I've outlined three and kind of the poor evidence to suggest that they help. And this EDAR is sort of a fancy way of just allowing people to eat and drink what they like. I think the term comfort feeding has also been used quite a bit. And in the literature, I thought that I liked this term because I think comfort feeding has a connotation about like very much at the end of life for patients and their families, maybe talking about days or weeks. And I think there's a use of this metric when it's maybe not quite at that end of life. So the UK was actually trying to make this a little bit more regulated and commonplace, and they created some guidance for physicians, and this is the terminology that they use. And again, I think that this was again just a fancy way of something that we already do. It's very hard to study all of these things, as I've kind of alluded to, that it's not quite easy to randomize patients to this. There's so many complex decisions involved. And so again, it's not something that I can say has been adequately studied. Most of the patients who kind of accept this kind of eating method are usually at the end of life, and that's just been something that has been shown over time in the literature. So it's hard to say what will happen in terms of reducing aspiration risk for a group of people that's maybe not quite at the end of life. Okay, so I thought I would end with a case that I just thought really illustrated all of these issues beautifully. The patient was a little bit different in his pathology, but the principles are the same. This was a case out of China that was published. This gentleman was a worker in China, a very pious man. He kind of worked, he didn't have any family. He worked in a factory and he developed a throat cancer. He was hospitalized with aspiration pneumonia, and the team spent a lot of time trying to figure out diets for him and ways for him to get nutrition. He also had a lot of pain when he was swallowing, so he required medications for pain. And this man said, listen, he's following all of the doctor's orders. And he said, I've really, really, really would like some fried chicken. And the team said, of course, let me try to get you some fried chicken. So they left the hospital, got the fried chicken, brought it back, and they helped him eat it. And as he's eating it, he starts to visibly aspirate. He has an increased oxygen requirement. He's coughing. He's reporting really severe pain. And the team says, okay, well, we certainly can't do this anymore. And he says, no, 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 I want to keep eating it. I've really not indulged myself in my life. I have this terminal illness. I really want to keep eating this chicken. And it kind of alluded to this issue, right? It's at the end of life, this man just wanted to eat some fried chicken. And, the team felt conflicted. They're not trying to make him worse, but they also really want to respect his wishes and help him enjoy this chicken. So, food is just such a fundamental part of life and a fundamental part of connection. For individuals and then in the community for families as well. And the way we feed people, I think, goes far beyond the implications medically. And I think the biggest takeaway I had in looking at this literature is that there is less evidence to support some of these interventions than perhaps we had thought. And when the evidence isn't as strong, I think considering these other factors, such as the community aspect, the pleasure aspect, and the connection aspect at the end of life or for patients with terminal swallowing difficulties is even more important. I can't thank you all enough for inviting me. I'm sure, I hope I didn't go through this too quickly. Brad and I are more than happy to take questions. Um, and again, we really thank you for having us.
Thank you so much for that. I don't see any questions in the chat. I also have a question, and if there are no others, then we'll allow Marty to ask his. But my question is, I had early in my nursing career, a case very much like the fried chicken situation, but it was a little more violent than that, in which it was choking, requiring Heimlich situation. And looking back was probably one of those moments that put me on the path to palliative care. But aside from that, I'm wondering if, in your opinion or in your research, you find that there is differentiation between a situation like that and an aspiration where, eventually would lead to pneumonia.
Yes. The short answer to your question is yes. I think that that distinction is an incredibly important one, and one I would argue we don't make enough because we're not, like, again, we don't want people to be choking and having these macro aspiration or, again, like a choking or discomfort maneuver. And I do think there's like a middle ground where you can kind of figure out the textures that are going to lead to the discomfort, which is choking or dysphagia and pain, versus this kind of silent event. So I absolutely think there's a difference. And
And
I
just
think there's, go ahead.
the fried chicken story kind of made that seemed to me not very middle ground.
Yes. And it was, again, this person was kind of awake and able to engage and kind of say, like, despite all that, it was still something he enjoyed. And again, that part I think was the challenge where, um, what risk do we accept and what risk are we trying to mitigate as a medical community? Um, and I don't have an answer. Brad, I don't know if you have anything else
I
to
think
add.
I think the when these things happen, when this comes up, like it's like a turning point in terms of the conversations that we have with patients, where it's, you know, whether it's a patient that is, awake and alert and able to communicate, or patients who you have to communicate through their family because they aren't. But I think this sort of like triggers, like these are like terminal type events, and now we need to talk about how do we navigate this. Like you may want to eat like a whole fried chicken, but there's not really a safe way in terms of like, we can't do the Heimlich maneuver every minute to do that. So like, is there a way that we could like puree it and we can acknowledge that's not really what we want? That's not the best way to do it, but there's also not a great way to have you eat it either. So I think it really is just like these trigger conversations where like, for the most part, like the end is near, and how do we balance like people's values and what they want with what we can do, in a safe and actually not even safe, but more of like a practical way. Like it's not even practical to like have people doing Heimlich maneuver over and over again, right? And so I think that it just triggers the opportunity for conversations about what's happening because none of the answers are good answers.
I believe Dr. Lau has a question.
Yeah, thank you. Good morning. So I love that you named or that you've introduced us to the term EDAR, that we have a name for that idea of we're going to let you eat and we're acknowledging that there's risk. Because I think that that's, when if we just put, regular diet in the chart, that feels disingenuous, I guess. And I'm not even thinking straight up about medical legal aspects per se. It's just, it allows us to document, and so I guess in that way I am, but it allows us to document that we've had this discussion with the patients and the risks are understood. And I think I love the idea that that enables, the whole team, all of the care team, to understand where the point is. The question I had kind of regarding this, but also it sort of links back, and I apologize, it's linking back a little bit to our question, our episode last week, where it was a little bit more focused on dementia, but I think this comes up with the aspiration patients as well. The guidelines for PEG tubes, I guess where I struggle is that the guidelines for PEG tubes say that there's, no benefits in general. And there are the risks, of course, with the procedure. My issue is that what they compared them to, the no benefit, was compared to, careful hand feeding, which that is a huge burden to families. And so I guess my question is really where I'm going with all of this is all of this requires a huge discussion And I'm wondering what your thoughts are about, about that distinction, that the no benefit comes with, careful hand feeding or modified diets that a lot of people won't actually maintain. And so I guess that's my question is how do you see that, especially when you were talking about kind of the New York stratosphere where patient autonomy is winning in many ways. And I don't think that's a bad thing at all. But I guess that's kind of my question. Sorry. And I know it was a really long-winded way to get there.
I I think with the way that I think of it, like I was saying, is that I think this is like when we have this conversation, it's kind of a turning point conversation. And it is a conversation where it's like, on one hand, we could put a peg tube and it has downsides to it. On the other hand, we can do other things which also have downsides to it. And I think it's just acknowledging like this is a bad situation and there's not really a good solution for it. And there's risks on both sides. And I think, if people aren't able to do hand feeding, et cetera, it sort of changes like some of what you're able to like weigh out, I guess. But I think the most important part is saying like this is like when we're having this conversation, this is almost like a terminal event, or it's like when the patient, an elderly patient falls and breaks their hips. It's like this is the beginning of the end, and we need to start talking about what to do. And there aren't good options in terms of feeding or preventing things. So what are the values that are like most important during this time? And maybe we can come up with a solution. And some people like in terms of like patient autonomy, et cetera. But some people in New York, like it's like feeding them is like the most important, whether it's a peg tube. They don't care what the risks are. They don't care that they're restrained. They don't care that they're agitated. Like their value is that like getting food into the stomach is the absolute most important thing. And as long as we've like had that conversation, at least helps me feel better about doing that, that like we've gone through all the risks, all the potential benefits or not, and they've accepted this. But it's like the conversation I think is like the most important part.
Thank you.
I think have been, oh, I'm sorry. Go ahead.
No, please go ahead.
I think this is so hard to study. And I think that was the other piece that like kind of stood out to me. There's not going to be, I don't think, any really help. I don't know what the future holds in this area. I hope there will be kind of more investigation into this. The cynical side of me points out that there's not an exciting drug or device, and so the funding for it will be limited, especially in this climate. But again, as you pointed out, the comparison group for a peg tube was something that we don't do. So, finding anything that's going to be kind of our golden ticket moving forward is going to be hard.
Thank you. Dr. Ramafinger has a question in the chat, wondering how you navigate EDAR and code status.
That's a great question. I think Brad kind of alluded to a lot of this. My other addition to that is that distinction between, as you mentioned, Patrice, like a macro versus a micro aspiration event. The importance of ensuring someone is not importance. I would say the making sure it's congruous that someone is perhaps DNR, DNI if they're having macro aspiration events. The timing is much more critical, especially if we're talking about, within the last days of life. The micro aspiration events, that's something that I hope that over time patients will understand that will lead to the ongoing illness, as we've sort of pointed out. But the urgency of it, I do find a little bit less critical. So it often takes more than one conversation. It does to me. I do find it frustrating, and when someone wants to feed their loved one and they also want them to be resuscitated. Again, in New York, that can exist. But again, the timing of it and the urgency when it's kind of these micro versus macro does impact it. I don't know if you have anything else, Brad.
Yeah, I think the other thing to think about too is just that, NPO doesn't also prevent really micro aspiration. It prevents macro aspiration. And so if somebody's NPO, it doesn't mean that they're not going to have aspiration pneumonia in the future. So there could also be distress about like this person is full code, full intubate. We made them NPO and they're also still going to get aspiration pneumonia because there's no cure for aspiration pneumonia. Like NPO is not a cure for it. So I think the same thing is it's just like when this is happening, it's like even if somebody's NPO, and if they're full code, full intubate, like that should also trigger, like there should be distress around that too, just in that like this is going to keep happening even if we made them NPO or not.
I think that's an important nuance, but I do find as palliative care specialists, we'll get the challenges with the rest of the care team, just being really frustrated and a lot of moral distress on if we're going to allow uh, uh, eating and drinking with acknowledged risks and their full code, and we can't possibly do that, and then having to help them work
Yeah,
through
I actually this is
around that.
remind this conversation's reminding me of someone who we brought to our ICU, and we were actually doing bronchoscopies, I think at least once a week. Like, there was like cottage cheese like in their airways, like because that's they were just like, and we were having this exact issue, and it was the moral distress, the resources involved. It's not easy.
Yeah. Marty, did you have a question?
I do and I don't. It's kind of been hinted at. I will still share sort of. I I feel like depending upon what paper I read, I have a slightly different opinion about all of this. There's a part of me that wants this to feel black and white, and I know it's not black and white, right? But I mean, there's a part of me that wants to say, hey, we've got this evidence. Maybe it's not perfect evidence, but we have this evidence that it's not beneficial, at least in maybe dementia at end of life. We'll just take that one caveat. It doesn't prevent aspiration. It doesn't improve mortality. And maybe it is harmful. Maybe it increases the risk of restraints. Maybe it increases the risk of wounds. There certainly is a procedural risk. In that setting, is culture, is autonomy, is that enough for patients to demand this? Isn't there enough there to say that this is objectively wrong in dementia at end of life? And there's a part of me that wants to feel that way, but I think it is more gray than that.
Mhm.
There are patients that I take care of, and I'm sure you all take care of, where it feels like the wrong thing and it causes moral distress and
Yeah.
dread.
And I think that the moral distress that like people feel like, across all the different disciplines in medicine when this is happening, just as an indicator, and this is like preaching to the choir, is just like we don't handle end of life care well in the current sort of like medical system. And so like there's no answer to this situation because it probably shouldn't be a situation that we're dealing with all the time, right? Like ideally people would be at home, et cetera. But we medicalize the dying process so much that we're then surprised that it doesn't fit right because it's like a square peg in a round hole. So we're like trying to allow people to die comfortably, but at the same time doing all these medical things all around them and then wondering why it doesn't fit correctly. And I think that's the part that I think about. And when it helps me manage when the team, there is all kinds of like interdisciplinary moral distress that comes up. In some ways, it reassures me that it's like, people are uncomfortable by this because it's an uncomfortable situation that we're in. And I don't know, that's how I tolerate it or deal with it.
Yeah, I think I had mentioned briefly before we started, like there were some at some hospitals I've worked at, there are services who require either a palliative care or ethics consult prior to the placement of a PEG tube in someone with dementia. Marty, you had asked if it changes
Yeah.
outcomes. I don't, I actually am not sure off the top of my head. And as a systems level, it sounds like you talked about this last week, that there are some things to do. And maybe that's something that we could, in terms of studying it and looking at evidence would be a way to actually kind of investigate and give families some information.
Well, I see no other questions in the chat or hands up, and it is 10:10. So with that, I want to thank you both for being here. It was a wonderful presentation and a lot of food for thought. Thank you for putting up your contact information. So everyone have a great day.
Thank you guys so much for having us. We really appreciate it.
Well, thank you. Bye.